and fertility units of the University of Naples Federico II. And together with Dr. Esteves, he's a co-founder of the POSEIDON group, and he's my friend. Please, Carlo.
Thank you, Filippo, for your nice introduction. We have a lot of co-founders of POSEIDON, including you, today, and I do thank you for your presence today. Usually, I start with thanking who made possible the event, but in this particular case, I would like to thank all the scientific societies, because it's one of the few cases where 5, if I remember well, scientific societies from different countries supported this initiative. And this is very important because it is the beginning of an incredible network. I was thinking about a funny thing concerning the presentation by Nina before. And let me tell you something just to... I remember that talking about Poseidon, Poseidon was created by a group of friends during a meeting in Naples. And at the end of the meeting, we spent, to conclude the information, our day in the thermal bath in Ischia, which is called Poseidon Thermal Bath. And this is very important because these gardens, thermal baths, were very famous, are still famous, but very famous in the past because people from the world, all over the world, came there for therapies, including fertility. Yeah. So we're convinced that thermal bath, and it is partially proven, can improve fertility. And it was true because a lot of them come back home that were pregnant. The only problem was that at the end of the history, they discovered that all the children were very similar to lifeguards of the gardens. So probably it's very good therapy because it was mentioned before as therapy changing partner. It was an old strategy for this. So let me go straight to the point just to tell you something funny. But this is my disclosure, and I do apologize because you will realize that some overlapping is there. But I think that it's more important to be sure that we are perfectly aligned on this concept than making something lacking in the information. Why Poseidon classification, Poseidon system was created at the beginning? This is an historical starting point, the Bologna criteria for poor ovarian response. We have to thank the scientific community involved in this operation because it was the first real attempt to find a common solution for definition of poor ovarian response. It is famous, the fact that before this classification system, we had at least 47 different definitions of a poor ovarian response in the literature. So it is an attempt, the first one, to give an order, to give something well-structured that could be shared in the scientific community. So 3 major criteria for defining POR: advanced maternal age, previous POR, but for the first time, anti-Mullerian hormone and anti-follicle count were introduced for defining the problem. At that time, it was not so much common. Basal FSH was dominant. So you had to have 2 out of 3 or 3 criteria, but minimum 2 out of 3 to say that the patient is a POR or at risk for poor ovarian response. So this is something that is apparently good, is a good starting point, but there are some problems there. Because what is the problem? We need to categorize in the best way. We need to understand that poor ovarian response can be related to different pathogenic mechanisms. If we put all the patients in one basket, we run the risk of not understanding which therapies are working in a specific subgroup or low prognosis segment of patients. Let me give you an example. If you combine the major criteria, 1 plus 2, 1 plus 3, 2 plus 3, or 3 of them, you can have different combinations. But you run the risk of having in the same study or in the same meta-analysis, a young patient, for instance, 33 years of age, with 2 episodes of a POR, and a patient with 44 years of age. So you can understand that the prognosis, despite they are both poor ovarian response patient, the prognosis is totally and dramatically different. So if you want to see the problem by scientific point of view, if we design a randomized controlled trial, we run the risk of having a good sample size in general, but a small sample size for any one of the single groups in ex post analysis. So it can be underpowered for understanding in any single category if the drugs or the therapy works or not. The second problem is related to the first one, is that in the Bologna criteria, the oocyte quality is not considered. We say 3, 4, 5 oocytes. The number of oocytes is very important. It's a very important, crucial prognostic factor. But 5 eggs can be even sufficient in a patient 25 years of age because the rate of euploidy is very high. And on the other side, 15 eggs, 20 eggs can be not sufficient in a patient 43 years of age because the rate of aneuploidy is 90%. So number of eggs, yes, but now we have clear definition here by here of the rate of aneuploidies. So we can calculate what is the expected aneuploidy rate at any given age, and we can calculate the number of eggs we need to try to counteract, to compensate for this incredible high rate of aneuploidies. And the third concept that in Bologna criteria is not considered is the sensitivity of the ovary to exogenous gonadotrophins. You can have 2 patients both having 5 antral follicles reaching maturity, 5 eggs retrieved. So by prognostic point of view, they are the same if they are similar in terms of age, because the rate of aneuploidies is the same, and the prognosis is defined by the number of eggs. But the first patient in our example had 5 major follicles and probably 5 oocytes moving from 15 antral follicles. The second one had 5 growing follicles moving from 5 antral follicles. So the sensitivity of the ovary of the second patient was dramatically better than the sensitivity of the ovary of the first one. So if I have to consider a second stimulation, in the first patient, it makes sense changing stimulation, increasing the dose, moving from an agonist to antagonist, because the potential is higher than the final results. So I can improve stimulation. But in the second patient, 5 eggs from 5 antral follicles, the ovarian sensitivity was perfect. So I don't have to change my stimulation. I need probably to stimulate twice in a duo-stim or accumulation program in general. Because if I need more eggs, I cannot have more eggs than the expectation from antral follicle count. So this has to be considered because these 2 patients have a probably similar prognosis, this is to be proven, but at the same time have to be treated in a totally different way in a second cycle. And another problem in Bologna criteria, which is related to the slide I showed you before, is that the cutoff of age, which is considered, is 40 years of age for defining poor ovarian risk for poor ovarian response. But as you can see here, 40 is a moment where the aneuploidy rate is dramatically high with an year-by-year dramatic increase in an acceleration year-by-year from that moment. But if you have a look, and I will show you better later, if you have a look, there is an incredible difference between 35 and 40. You can see that the rate of euploidy are quite similar between 25 and 35 years. The decrease in euploidy is very small between 25 and 35, but after 35, there is a dramatic fall in the rate of euploidy. So the age between 35 and 40 is very important. We cannot have 40 years of age as cutoff for considering that the patient is a lower prognosis patient. So these are the historical reasons why we decided in a group of friends to meet and to find a solution for considering not only the number of eggs retrieved, but other variables, including the year-by-year change in the rate of aneuploidies, including obviously markers of ovarian reserve, but also including the concept of ovarian sensitivity. So you had lower number of eggs, but what was the initial expectation? Few eggs from an adequate antral follicle count or few eggs from a small antral follicle count, which is totally different. So it is just a compromise, a way to find 4 different groups that have to be different in terms of pathogenesis, therapeutic requirement, possibility of therapy. So discriminating among low prognosis subgroups and groups and subgroups of a patient is the aim of POSEIDON. So we move, this is very important, from the idea of POR, which is important obviously, to the idea of low prognosis, which is totally different, where POR is a crucial part in the puzzle, but is not the only variable included. So from POR to, this is important, low prognosis. So basically groups 1 and 2 are patients that had less eggs than expected, Patient 3 and 4 are patients that had few number of eggs, but from a small with reduced markers of ovarian reserve. So where it is expected that the number of eggs is lower. On the vertical distribution, on the left side, meaning group 1 and 3 are patients below 35, meaning that they have a lower number of eggs, but still good quality in terms of rate of euploidy. On the right side, groups 2 and 4 are patients that have a lower number of eggs, but with low ovarian quality, meaning higher rate of aneuploidies. So we have 4 combinations, and Professor Fischer later on will go deeper inside in this. And so it is not necessary to say that antral follicle count and anti-Müllerian hormone perform better than FSH in predicting ovarian response and prognosis. But I want to tell you that we proposed the cutoff of 5 for antral follicle count and 1.2 from MH because we found this from the Bologna criteria and consistent with the clinical practice. But it has to be validated, and I have to thank the incredible work that Sandro and Akan and Professor Wong made, putting the data from 3 centers from more than 9,000 cycles, and they definitely demonstrated that the cutoff value of 5 for antral follicle count and 1.2 for anti-Müllerian hormone are very good in terms of sensitivity and specificity, meaning that the area under the curve is approaching 0.76, which is quite good. It's not perfect, but obviously. And they also defined ideal cutoff values for predicting suboptimal response, meaning between 4 and 9 oocytes, identifying with the area under the curve even 0.8, a cutoff of 12 for antral follicle count and 2.97 for anti-Müllerian hormone. The group 1 and 2 are divided in patients with very low prognosis, meaning less than 4 oocytes, or patients between 4 and 9 oocytes. Why this difference? Because it has been proven by many papers. This is, in my opinion, probably the one of the best from Brussels group, demonstrating that at any given age, the prognosis is strictly related to the number of eggs. So there is a difference if you have between 1 and 3 oocytes, and you have 4 and 9 oocytes. Both are lower the expectation, the ideal, that is between 10 and 15 for fresh cycles and even more than 15 for cumulative live birth rate. So we can say that the optimal is group C, between 10 and 15, and below 10, it could be suboptimal, between 4 and 9. We can say poor, between 1 and 3. And Poseidon takes into account this information because there are subgroups that in group 1 and 2 are divided according to the number of eggs, to try to make the groups even more homogeneous. So that's the reason why, and Dr. Conforti will explain it, we introduced a new marker of ovarian response, which is FOI, which is an index that gives you an idea of the sensitivity of the ovary. It's very easy. It's the number of mature oocytes in relation with the initial antral follicle count. So the concept I explained before. If you have less than 50% of, in terms of number of oocytes, with respect to the initial antral follicle count, the FOI is low, meaning that the ovarian sensitivity is low, and this is something that is very important for defining that the patient is potentially belonging to group 1 and 2 Poseidon. The cutoff of 35 years of age is what I mentioned before, and the fact that after 35 years of age, there is dramatic drop in euploidy rate with very low inter-individual variability. You can see that before 35, the euploidy rate is very high with an incredible inter-individual variability. After 35, it goes down, the euploidy rate goes down dramatically with very smooth inter-individual variability. So I want to conclude my presentation with something that Sandro will explain better. We need a final validation. The final validation is Poseidon able to discriminate, to identify subgroups that are different among intergroups analysis, but are homogeneous inside. And yes, it seems from many papers from this that has been recently published, but this is an analysis we made in more than 9,000 cycles. You can see that any given Poseidon group and subgroup have a different prognosis in terms of cumulative live birth rate. So they are different. And altogether, they are lower in terms of prognosis than non-Poseidon patients. So Poseidon as a whole is able to detect low prognosis patients. But the single Poseidon group differ in terms of pathogenesis, prognosis. This is very important because it's totally different from Bologna criteria, where the combination inside are quite similar in terms of live birth rate. The second point of Poseidon is provide something that is an endpoint, not by scientific point of view, but in the daily life and clinical practice. Tools for understanding, matching. So the concept is, I know the euploidy rate for any given age. I know it. This is an information. So I can theoretically calculate, consider for any given age, fertilization rate, blastulation rate from my center or from literature. I can calculate with a nice counseling with the patients the ideal number of eggs I need for having at least one euploid blastocyst. This is historical, provided by the work of Sandro. This is a calculator that is an incredible counseling tool. You dialogue with the patient, you explain, and you calculate with the patient the number of eggs that she needs for having at least one euploid blastocyst. You can even differentiate 70, 80, or 90% probability of having at least one euploid blastocyst. No, this is very important because the patient can understand what is the target. And so what is the Poseidon? This calculator has been validated by an intriguing and very active network, thanks to Filippo, Professor Baldi, to Akan, Professor Halley, Professor Wong. And the system is validated, and in the next days, Sandra and me will present an upgraded version of the calculator. Nowadays, today I have to talk about history, and this is the first attempt, but we found it very useful in the daily practice for counseling, because the flow is this. I measure the ovarian markers, so I know the potential of the patient. If the ovarian markers are below the expectation, according to age, I can say that the patient is group 3 or is a group 4. If the ovarian reserve is adequate, the expectation is a good ovarian response, but if following one stimulation the number of eggs was lower than expected, I can say that according to age, a patient is group 1 or group 2. So I categorize patient, and I can say your prognosis is this, because the system is able to discriminate and to predict different prognosis segments. And then I say, this is your ovarian reserve, this is the number of eggs you need. So this is your potential, this is the number of eggs you need. So we decide together if moving to single stimulation, double stimulation, and it is a very useful, I repeat, tool for using ART calculator for counseling patient about this. So I leave you with this concept. POSEIDON is not a classification for poor ovarian response. We have a Bologna criteria or something. Bologna is a way to identify and stratify patients with low prognosis according to distinct categories that are homogeneous inside. Any category is homogeneous inside, but heterogeneous when you compare each other in terms of prognosis, pathogenesis, and possible treatment strategy. I don't want to take time for reading conclusion, because sometimes conclusions are hypertrophic with respect to what we said. I hope to, I have been clear, or I did my best for giving the historical perspective of POSEIDON. But I take the last few seconds for thanking all the people in our unit and all the POSEIDON contributors in the years. And in particular, I invite you to join us, because POSEIDON is an open space. It's not something, so anyone has the website will be presented, but anyone has ideas, want to propose trials, want to give contribution in making the POSEIDON community growing, is welcome. So thank you very much for your time and attention.